There we go. It's recording again. Okay. All right. So it's recording. So that's the first thing. Kate will edit this out if we put it on YouTube or anything. So don't worry. And then let me go ahead and start getting onto Facebook Live. And then here we go. So live on Facebook. And I'll let you know when we're live, or I'll start talking because I'm starting anyway. So, but it's always, I guess, a game. And every single presentation, I'm like, I think we're live at the start. Zoomers requesting access. Ooh. Okay. Okay. Goodness. This is really weird. This isn't letting me. Oh no. There. Okay, we got it. All right. Let me go ahead and get the. Sorry, there's a lot of steps to putting it onto Facebook Live. It's like. I think I'm getting used to this because we've done it a lot now. All right, let's see. Choose where to post your Zoom meeting. Got that. Okay, I'm going to go ahead and go live. And then let me find my Facebook presentation. Okay, hi everyone. We are just about to get started. I'm here with Dr. Magaña, and we are, let's see, post from the current slide. Sorry about our little technical difficulties. I'm Jackie Benestante. I'm the Deputy Director for the Autism Society of Texas. And I am going to go ahead and share my screen and show y'all what we are doing this evening. We have Dr. Magaña with us, and she'll be discussing reducing racial and ethnic disparities for children on the spectrum. And Dr. Magaña is a PhD in MSW, and she's also the newly appointed Executive Director of the Texas Center for Disability Studies. And she's a professor in autism and neurodevelopmental disabilities in the School of Social Work as well. So she is really well known, and we're really excited to have her talk on this topic. So I'm going to stop sharing my screen here, and I'm going to let Dr. Magaña take over and talk to us about this important topic. So thanks, Dr. Magaña.
Great. Okay. Really excited to talk to you all. And I'm going to share my screen. Let's see. Does that look okay, Jackie?
Yep, you got it.
Okay, great. Yeah, so I'm excited to talk about this topic. And I'm noticing that it's not. Oh, okay. Now it's moving. Got it. Okay. So I'm going to talk about, first of all, why is it important to examine and address disparities, and sort of what do we mean by that, by disparities? And I'm going to talk a little bit about the research on racial and ethnic disparities among children that are on the spectrum. And then I'll give you some examples of interventions that I've been involved with to help reduce disparities. So, so first of all, what are health disparities, right? We hear that word a lot lately, and especially with COVID, we're hearing a lot about health disparities, right? And so it's really important to think about it. It is differences, but not all health differences are health disparities. Health disparities are health differences that that affect adversely socially disadvantaged groups. Usually, it's usually groups, racial and ethnic populations, or around nationality or socioeconomic resources or social position, things like that. So it's usually disadvantaged populations that are experiencing poor health outcomes. And this is a graphic that I think you may have seen. It's going around the internet a lot, but it's talking about what is the difference between equality and equity. And so equality means that everybody gets the same thing, right? And so if you could see the graphic on the left, you see that all the kids who are trying to reach the apples have the same level of soapbox under them, right? But it doesn't mean that, that doesn't necessarily lead to equal outcomes. So a couple of the children aren't able to reach the apples, right? So equity is where you would be providing more resources for those that need it, right? That to be able to reach those outcomes. And so I think that's a really important distinction. It's also not always just about the individual, like in this case, it's depicting a short person being the one needing more resources. And I should take offense to that because I'm a very short person, but actually it also can be, many people are disadvantaged because of structural issues. So we have to keep that in mind too. So it might be more like a slope going down where the person who can't reach the apples is on a lower slope, and that's a structural issue. So we also have to think about it that way as well. This is just some data from the CDC. The Center for Disease Control does regular monitoring of autism prevalence, and in the rates that they reported from 2013 data, they are showing that if you see the bars, the green bar is African American, the red bar is Hispanic Latino, and the white bar is white. So the Latino children are less likely to be diagnosed compared to white children. African Americans are at least in this latest version, catching up a bit. Although if you broke it down by the different states they looked at, there's different rates in each state where African Americans may be lower diagnosed. So we're talking about not necessarily prevalence, but diagnosis. So we know that it's really hard. Many of you know how difficult it is to get a diagnosis. You have to go through a lot of hoops, a lot of iterations. And so people who have more resources might be able to do that easier, even though it's still hard for them. People with fewer resources or less access as far as neighborhoods or other kinds of things will have a more challenging time. And with Latinos, some Latinos in Texas and other parts of the country have a language barrier as well. And so that could create barriers, or maybe immigrant families who don't understand our service system. And so that, could be why you're seeing a lower rate of getting diagnosed with autism, because we're assuming that that autism impacts everybody equally. There's no reason to believe that any of these groups are impacted differently or affected differently by autism. So it's more about getting that diagnosis and accessing those resources. Interesting, the second box shows the percentage of children in the surveillance that they did that have an intellectual disability. And you probably remember just like maybe 5-10 years ago, they used to think it was like 60% or more people with autism had an intellectual disability. And I think more studies are showing that as we're including more people across the spectrum, that's not particularly true. But you can see big differences here where the white children, 22% of them have an intellectual disability, and the rates are much higher for Black and Latino children. Now, that doesn't mean that Black and Latino children are more likely to have an intellectual disability if they have autism. It means that the people in the system, right, that they're actually able to capture in the system are more likely to have an intellectual disability. So that could be that there are a lot of Black and Latino kids that are out there that are not being diagnosed at all, or that maybe on the level of having fewer needs, they might be more likely to not be in that system, whereas the white children might have more children across the spectrum in the white group. So those are just highlighting some disparities. Other disparities that have been found in relation to diagnosis are that Black and Latino children tend to be diagnosed later in many cases. So we all know that it's really important to get that diagnosis early. If you can get it before 3, and you can take advantage of the birth to 3 programs, but also just getting early treatment is super important, right? And so if a child is getting diagnosed at 5 or 6, they're missing a whole lot of treatment, during those years. And then we also know that Black children are more likely than white children to be misdiagnosed. So they might be diagnosed first with a conduct disorder, ADHD, when what they really have is autism, right? And we know ADHD co-occurs a lot with autism as well, but so they may also have that, but often they're not given the autism diagnosis when they should be. And then we also know that low-income children are less likely to be diagnosed and are diagnosed later as well. So data is showing that. This is a study that I was involved in where we're looking at healthcare of children with autism and other developmental disabilities. And we're trying to assess, we're looking at a national data set here. It was a national survey of children with special healthcare needs. And so this is representative data on a national basis. And we're trying to find out what the quality of healthcare was. So this is more than likely, and the parents are reporting this, but it's more than likely the interaction with the pediatricians, right, or the providers of the children. And we see that Black and Latino children are less likely to say that the provider helped their parent, helped the parent feel like a partner, or provided enough time, or were sensitive to the family's values, or listened to parents. So, and those differences are even more stark between white and Black children. So that's another area where there are disparities. This is another study we did where with national data, they had a special sample specifically of children with developmental disabilities and autism, and they did have more of the specialty services in this questionnaire. So we're able to look at that. And what this is showing, so one thing is generally, if you have a child who is more severely affected, that means they're going to need more services, right? They have more support needs. And so they should get more services. And so that's a general pattern you would expect. So what we see is that the columns on the left are white children and the columns on the right are Latino children. So that is true with the white children, where if they're more affected, need more services, they get more services. Whereas with the Latino children, they don't. So that's another way to look at disparities. So really trying to understand why it is that the Latino children are not getting the services that they need for more severely affected conditions. And so that's just kind of a few studies that show disparities. There's a lot more of them emerging out there, really documenting some of these disparities. And a lot of it has to do with resources, right? So having programs and services that require private insurance or private pay, those things that's barriers to people who can't afford those services, right? So there are a few ways to think about reducing disparities. One is to develop culturally tailored interventions to help empower families on an individual and family level and help them navigate systems and advocacy and things like that, right? Another thing, so there are different levels you can approach that. So you might also want to provide training to providers to reduce disparities. So we know that we can't put all the onus on the families themselves, right? We have to look at the systems. And a lot of times there's unconscious bias going on among providers. Why are Black children being diagnosed with other disorders first before autism, for example? Is there some bias going on? Is there some training that providers could use around that? And also just around the quality of care kind of issues. If the racial ethnically diverse groups are reporting that they're not getting that quality of care, what can we do at the provider level to train providers? And then there's policy levels, right? Interventions that could be done. And a big example in Texas is, we know that, for example, with for ABA, currently you can't use Medicaid to fund your ABA. So if child is low income and that's their insurance, they're not going to get ABA, right? And so in Texas, I know a couple of years ago, the legislature voted in, I know the Autism Society has been working on this issue as well, was voted so that Medicaid would cover ABA. It still hasn't been put in place yet, right? But that would be an example of a policy level intervention. So I think there were a lot of people that actually advocated for that legislation to be passed. That wasn't the end of it, obviously. There's a lot more to do to try to get into implementation. So those are just kind of 3 different levels that you might think about in terms of how to reduce those disparities. And I'm going to talk to you about the culturally tailored intervention part, because that's a lot of what I do. And so just in my experience working on interventions and culturally tailoring them for different populations, these are just kind of best practices that I've seen. So involving stakeholders, super important, right? So that means involving the families themselves from those communities, autistic individuals as well, if you can, and providers and other stakeholders in helping to develop and think about the intervention, and shaping it that you're working on. And then also, I think a practice that I used a lot is sort of a peer-based approach to delivering an intervention, and I'll talk a little bit about that. So if it's an intervention for parents, having other parents who are peers to help deliver the intervention or help with recruitment or different aspects, right? If the intervention is for autistic adults, having autistic adults be the peer part of that delivery. And then it's really important, of course, to make sure if you're creating new materials or adapting materials that they're translated into the language that you want to use, but then also making sure the content is relevant to that group. So it might mean some changes to the content. So let's say you're taking an existing evidence-based intervention, and you want to apply it for a particular underserved population. It's important to take into account, do you need to translate? Do you need to make some changes related to the content? And then making sure things are accessible and reducing effort for the families and removing barriers, right? So for example, I bet you if we did a map of Austin and put on the map where all the ABA providers are, you're probably going to see a lot of pins on the west side and not very many pins on the east side, right? So, that's an example of accessibility, or like, these providers need to be in the communities that are underserved, right? So that's an issue, and just other barriers like transportation. If you wanted people to show up at a clinic in Austin, our public transportation system is not very good. And so to expect people to get, and especially with gentrification, low-income folks are having to move to the outskirts of Austin and all over north, south, east, and west, right? So to have people come from one of those locations on a bus might take a couple of hours. Or they may not have a car, and so cars are almost like required in Austin in order to get from one place to another, right? So those are barriers that we have to take into account. I'm going to talk a little bit about the ecological validity frameworks. I can tell you what I mean by that. So we developed an intervention called Parents Taking Action, and I'll tell you how we kind of use these different strategies I mentioned in developing the intervention. So I first developed with a team, developed a pilot of this intervention when I was in Wisconsin. So I was at the University of Wisconsin-Madison, and we worked with a group in Milwaukee. There was a Spanish-speaking support group. We were interested, and actually there was an organization we were working with, a parent training and information center that had a support group in Spanish. And in talking with one of the leaders of that group, who was also a parent, she loved the idea of doing an intervention, educational intervention for the parents, but also using promotoras, which I'm going to talk about in a minute, because we had been developing a program with promotoras. And so what we did is we formed an advisory committee in Milwaukee. So that's an example of engaging stakeholders, right? And the advisory committee included family members of children with autism that were Spanish speaking and from the Latino community. We also had a pediatrician and a social worker who were both serving the Latino population, the organization we were working with. So a number of stakeholders were on the advisory committee. And again, I am going to talk about the ecological validity frameworks. You know what that is, and I'm going to explain a little bit about promotoras, but we use those different approaches. So this is a kind of an example of the ecological validity framework for cultural adaptation. And it was created by a psychologist, Bernal. And so it has these different dimensions, right? And so you want to, and I really like this because you could use it if you're trying to adapt any kind of program or materials that you have. These are different dimensions you might consider, right? I think it's just a good guide to use. And so we use this as a guide with our advisory committee to sort of talk about, as we were developing different pieces of the educational program, how are we considering these elements? And so language, right? You want to make sure the materials are in the language for the population you're trying to serve. You also want to make sure interventionists are, speak that language as well. And so in our case, we use promotoras or community health workers that were native Spanish speakers. So who are the interventions? Who are the people you're considering to use? And we use promotoras from the cultural and geographic communities of the families that we're trying to serve. So they had that sort of peer relationship. Metaphors, so you might in your material, think about using approaches that are culturally appropriate. One of the things we did, we learned from our promotoras some things like including stories at the beginning of each session, or including little sayings and having them as sort of discussion points or icebreakers, and incorporating cultural values, thinking about that, thinking about the goals. And most interventions do have goals, and it's important to tailor them for each family and child, right? And taking into account their sociocultural context. So do they have the resources to implement particular goals? And then we really found that we needed to have a very flexible approach. And so I'll explain to you a little more about the approach and how we did that. And then the context, one of the ways we overcame barriers in this intervention was by having it be a home visit model, so that people didn't have to travel from all over the area to get to a place, right? And it could be more individualized in terms of scheduling and that sort of thing. You don't have to worry about transportation and childcare in a home visit model. And so we developed this curriculum with the help of our advisory committee and our staff. And so there are kind of three main domains we had in this. We had 14 sessions, but they fell under kind of these three areas. One is psychoeducation. So really understanding child development and how it relates to autism, right? So what are the social communication kinds of milestones that children need to achieve? And then also just more detail about the autism spectrum and understanding the family's child's needs. We found that many of our Spanish-speaking families, they may have gotten a diagnosis 2 or 3 years ago, but nobody really told them what are the symptoms of autism, or how does it play out in their child. And then we also talk about what are evidence-based practices for autism, that where the research is showing, that there are good outcomes different interventions, and what practices there's no evidence for and that we should try to avoid. We do talk a lot about advocacy in this intervention, so really how to be an effective advocate, and then also in the school system, and also reducing stress for the parents. We know that parents are experiencing a lot of stress, and all kinds of all parents do. So how do we help them reduce stress? And then how do you talk about autism to other people and get other people's support to help the families? And then we actually go into evidence-based strategies that they can use. So we talk through a lot of strategies like, communication techniques and also challenging behaviors, reducing behaviors, and helping children make friends. So that our curriculum is based on those kinds of things. And so I want to tell you a little bit about the promotora model. So I was in Wisconsin, but I learned about what a promotora was in Texas. Promotoras are widely used in Texas. You probably are familiar with that. We had taken a class of students from Wisconsin to the Rio Grande Valley every summer. That was back in like 2004 or something like that, to work on environmental justice issues. And we worked with the Brownsville Community Health Center, and they had promotoras there. And so I'm like, what's a promotora? And so they explained to me that they were basically, health educators in the Latino community, and they could serve as a communication bridge. They're lay folks. They don't necessarily have a bachelor or master's degree. And they might provide education around a particular health issue like diabetes or health condition or mental health, things like that. And so when I learned about that, I said, hey, we should create an autism intervention using promotoras. That would be really cool. And so that's how we got to this sort of delivery mode. But we did make sure that in our intervention, the promotoras were mothers of children with autism. So not just people from the community, but also people from the community who are also parents and understood that level. So that's where the peer aspect comes in. These are our promotoras in Chicago. So I later moved to Chicago, and we did a randomized controlled trial of this intervention with in Chicago and also in California. So we had 2 sites. And so these ladies, they were just amazing. They had kids with autism. They had already been through a lot of, learning how to advocate and things like that. So they had a lot to teach. And we also gave them training in our curriculum so that they could convey that information to other families. There's a cake there because they just finished their training in this picture. And so you have to celebrate when you have training, right? And so we developed some materials for this intervention. We had a promotora manual in English and Spanish. And so that is basically, gives instruction to the promotora, but also provides the content. And then we have the manual for participants, and that didn't have all the specific instructions, but it still had the content for the family. So that each family got one of these. The sessions were 2 hours long on a weekly basis in home visits. The promotoras did these in home visits. And we did start out saying, okay, we could do this in an hour, but the promotoras came back and said, no, we can't do this in an hour. We need 2 hours because we're developing relationships and sharing stories and things like that, and which we want them to do. So we did extend it to 2 hours. And then we created videos and different little novellas and stories, did visual resources. We provided a lot of resources and materials for each of the families as well. And so, so I'm going to share with you a little bit about our results on this study. This was, as I mentioned, it was a randomized controlled trial. So what that means, you probably hear that word a lot with the vaccines, right? Because the way that they test vaccines is using randomized controlled trials. And it basically means that you're, for people who want to participate in the study, you're randomizing them to one group or another, right? So it's almost like flipping a coin, but the person, the family would would be in either in the intervention group, getting the promotora to deliver this intervention in 14 weeks, as soon as we've done some assessments, or you would be put on a waiting list to get the program 8 months later. So they were randomized in those two groups. There was no, we had no knowledge about which group was which, who would go in which group. So it was important to keep it that way, because you want to make sure that it's the actual intervention that's creating the change versus, versus just people wanting to show that they appreciate your program or something. So here, one of the things we were measuring is sort of efficacy or confidence in using strategies. So we asked them before the intervention and then after the intervention, whether they felt confident using the strategies that we were teaching them. And so you can see the difference between intervention group, where it went up quite significantly, but not for the control group. And so that kind of shows us that the intervention is making a difference for these families in that particular outcome. And then we also, we had a few parent outcomes, and we also had some child outcomes. So we actually found that the children reduced their social communication impairment between pre and post, but not so much in the control group. In fact, it went slightly up with the control group in terms of having a higher level of impairment in social communication. So actually, we weren't expecting child outcomes because we were focusing mostly on the parents. We didn't interact with the kids at all in this intervention, but we do see that it did make a difference where parents were learning something, they could then translate it to their children. We also found that children received more evidence-based services after the intervention, so than they were before the intervention, for the intervention group, which is part of reducing disparities, right? We want to make sure that these kids they're typically not getting evidence-based services, that they're increasing that. And so we thought that was a super important thing to find. I want to say that we were at the International Society for Autism Research Conference this spring and presented some of our more recent findings, because we also did a third time point of data collection. So 4 months after the intervention was over, we wanted to see if these outcomes could be sustained or maintained. And we did find that. We found that they were maintained over time, across the different 3 time points. And then the other thing that we just recently presented on is that we found that depressive symptoms among the moms significantly reduced. And we think, and it continued to reduce. So it went down at time 2 at this post period, and then it continued to go down at the third period. And that's super important because moms of kids with disabilities tend to have elevated levels of depressive symptoms. So we thought that was an important outcome. So just kind of summarize that parents generally were feeling more empowered. They were using more evidence-based strategies, and then that likely led to being able to access more services and reduce problems with social communication. And so I'm going to talk a little bit. I don't know, how are we doing on time? Are we doing okay?
Yes, you're fine. You can definitely keep going.
Okay.
Okay.
So we're talking about cultural adaptation, and we actually are doing a cultural adaptation of this intervention for Black families. So I have a colleague at the University of Maryland, Baltimore, Sarah Dababna. And so she started out engaging stakeholders, right? So they did focus groups with Black parents of children on the spectrum and Black professionals on the content of this intervention to see, should we make any changes to this program? And they conducted a pilot study with 10 families, and they were all from low-income neighborhoods in Baltimore. And so they really, they developed this model called the SHARP model. Wendy Shea is was one of the people working on this project, and she developed this model. So they really wanted to incorporate these aspects into how they deliver the intervention. So really understanding structural oppression and how it impacts the community, the historical context of the community, looking at the provider role, reciprocity, and looking at the power dynamics, right? So those are really important elements that they felt were important. And so they use a SHARP framework and engage parent leaders in the study, to work on disrupting services. And then their aim was in this study was to engage stakeholders and then deliver the intervention to identify what are the barriers and facilitators of that. So they did make some changes to the curriculum in the process. They changed the order of sessions, which is, they felt, at least the stakeholders felt they should be in a different order, which is fine. But they also importantly changed the manual so that they, we had a story of a young man at the beginning. Well, they changed that to a story of a young Black man that had autism and lived in Baltimore. And, and there were a lot of different stories throughout the manual. So they recreated those and also made sure that the pictures reflected the population, the photos and video recordings and things like that. A content piece that they added to this was information on police interactions. So that was something that that the families and stakeholders really felt was super important. So we hear a lot about Black Lives Matter, right, in terms of how people are treated by the police, but we also know that people with autism and other disabilities are mistreated by police as well. And there's a lot of misunderstanding of them, but especially if you're Black and also have a disability or Latino and have a disability, police may treat you in a different way than they would if you were white and have a disability. So really those kinds of issues were important to them. And so they did identify facilitators and barriers to their implementation to the 10 families. And they're working on a new version of, or sort of a larger study of it right now. But they did find a lot of cancellations. I mean, remember, they specifically were working with low resource families. So not all Black families are low income or low resource, but the ones that in this study were. And so there were a lot of challenges that they were experiencing, like violence in the neighborhood or housing instability, health issues of other family members, phones out of service, transportation, a lot of different challenges where you really have to take into account, these issues that families face. And they actually integrated a case management into the intervention to address some of these immediate needs that people have. They were much more flexible in terms of the appointments. If they couldn't do them weekly, they spread them out a little bit, and just taking it one step at a time. So that was that. That approach is still going on right now. We're working on a collaboration. We just submitted a grant with my colleague there in Baltimore that where we'll do a 2-site study in Austin, hopefully, and also Baltimore. If we get that one funded. So we'll see what happens with that. Then I have one of my former students when I was in Chicago is adapting this for Chinese immigrant families. So she translated the whole curriculum and intervention for Chinese families. And then she did focus groups with both Chinese providers and immigrant parents about this. And she really felt that that the intervention would be appropriate because we did originally develop it for immigrants, Latino immigrants. So there's a lot of similarities in terms of that experience. And a lot of people ignore Asian individuals or families in terms of services, assuming they're doing well. But that's sort of the model minority myth, right? And actually, she points out that there are a lot of low-income Chinese families that are immigrants in the United States. And so she talks about why she chose parents taking action for this intervention, and part of it being both groups being immigrants and also shared values like collectivism and familism. So she thought there were a lot of similarities there. And again, she held focus groups. Some changes they made to it is that they're using professionals and peer leaders. Of course, they don't call them promotoras because that's Spanish, right? But they, for each session, they're incorporating her. She's a professional, so she's an MSW, and so she leads the groups, but also incorporates the peer leader. And they decided to do it in group. And of course, with COVID, she's doing her dissertation during COVID, so they had to do it online. But that allowed her to actually recruit families from both Chicago and New York. So she did an online group for New York families and an online group for Chicago families. And so they were weekly 1-hour group learning sessions, and they had some pre-recorded lectures that lasted about an hour. So families would view that pre-recorded lecture, and then they would have this discussion group, and that seemed to work out really well. So she's writing up her results right now like crazy to defend her dissertation, but I would say it's a very successful project as far as what she did. And these are some of the things that they did in terms of making changes. They replaced the stories, with families that were from Chinese backgrounds. One of the things that their stakeholders, in their families, when they were doing the focus groups, brought up is there's a lot of myths about bilingualism for children with disabilities and autism. And many of you may have heard these myths too. Like sometimes they'll be told by professionals or others that, oh, you should only speak English to your child because they have a disability, and it's too complicated for them to hear 2 languages. And that's actually bad advice. So it's really important for kids to hear language, no matter what language it is, right? So to hear people communicating and talking and having parents talk to them all the time is super important at very young ages. And so to tell a parent that, oh, you should only talk English when they don't even speak English, it means that you're depriving that child of any language, right? So they wanted to add that content to it. And they also added a meditation for every session. And they moved some of the sessions around in different places. So a lot to talk about, right? So a lot of different projects and approaches. This is a program that we're doing here in Austin. And actually because it's remote, with COVID, we're doing it throughout Texas, not just in Austin, but it builds on the parents taking action intervention, but it adds some things to it. So I'll talk to you about that in a minute. And this is led by my colleague, Sandra Vanegas. And it's a grant that she got, and we both are working on this together. And so Aspen incorporates, goal setting with the parents, and is specifically focused on low resource families of any race, ethnicity. And so the training is in a systematic order. So we're mostly focusing on social communication. So really helping scaffold that learning with the child and the parent. But it also incorporates some coaching. So that's what Parents Taking Action did not have, coaching. And so this intervention has the interventionist, who's a student clinician, helps demonstrate with the parent, but also having the parent practice with the coach and getting feedback. And it also includes support in problem solving and focusing on daily routines. And this is sort of their the Aspen topic areas. It builds on, there are other social communication models like Project Impact with, I don't know if you're familiar, some of you may have heard of the skills program that they're doing in the communication science department at UT. So they use a lot of these similar topic areas. So for this study, it is a randomized trial where it's it's going right now. So we're recruiting for this study. We're looking for families that are between 18 months and 6 years old, or child between 18 months and 6 years old. And the child would either have a diagnosis of autism, or maybe they've screened for autism and are on a waiting list for an evaluation, or they're at risk in some way. So, and then by low resource household, we mean that either somebody in the family is getting Medicaid, the parent has a high school education or less, and the household income is less than 200% of the federal poverty line. So any one of those three items would qualify the family to be able to access this program. And so we're randomizing them very similarly to the other program into intervention and a control group. And so the intervention group gets 12 sessions, and there's a student clinician, and the students who are clinicians, they get intense training, and they're from different disciplines. So they're from communication, speech and language, social work, psychology, several different disciplines. And then we also incorporate the peer leader aspect of it. So we have parent peer leaders who join some of the sessions. And then for the control group, they actually get all the materials, and we do 4 check-ins with them throughout the 12-week period. So we're going to see how that works out, but we have materials that we've developed for that intervention. And then this is information which maybe the Autism Society can share with you if you're interested, the link. So if anybody's interested, they could go to that link, and they can put your information in, and we'll contact you and go through this process of screening for eligibility and getting you into the program. So if you know any parents of young children who are either with autism or at risk for autism. And it could be, and we offer this fully in Spanish and English. And so here's our contact information. So I think, and I'm just going to show you our acknowledgements of all the people who've helped throughout the years to put together the intervention, and our funders. And that's all I have. And I'm going to stop sharing my screen.
Great. Thanks, Dr. Magaña. Alrighty, so we have got a few questions, and I will go ahead and read them off. That was interesting information. So, so first of all, somebody asked, do you know if it's mostly doctors or schools that aren't diagnosing or identifying kids correctly, or is it both?
I would say both, because the CDC study, what they do is they pull school and medical records. So what they do is they pick a particular region. They only do 11 states, but they identify kids who are 8 years old at that time, and then they go back to all of their school and medical records to see if either they have a diagnosis of autism in any one of those areas, or if they have enough symptoms. Maybe they weren't diagnosed, but they have enough symptoms that they probably do have autism. So yeah, I would say both.
Okay, that's good to know. All right, and then are teachers or others in special education being trained about this at all, about the disparities and the lack of diagnosis? Are they receiving any information about this?
That is a great question. I wonder if they are. I don't know, actually, because I don't work in education. My main area is social work and working in the community and with families.
Yeah.
But it would be good to see if the education, the College of Education, if they do any work or training on this. I wonder.
Yeah, I know, obviously we do a lot of special ed advocacy, and we're just trying to still get them to learn about autism in general for everybody. So I don't know if they've gotten that, like, diving further into this, but
yeah, and I do have colleagues that in education that are doing research around schools and things and disparities. So there is some published research around schools and how parents perceive their educational experience across different groups.
Okay, interesting. And then is there research on outcomes for non-white kids who aren't diagnosed, who do have a diagnosis but aren't diagnosed? Is there research or any studies on them? I guess you wouldn't know.
They do have a diagnosis, but they're not diagnosed.
They didn't get diagnosed. I guess they were not diagnosed with autism, but they are autistic, or maybe they get diagnosed later in life. But it says, do you know anything about outcomes for non-white kids who are not diagnosed?
I think that's an area we really need to research a bit more. I'm trying to think if I know of any, because I kind of get where the person's coming from, because a lot of people are, if they're not diagnosed early, they don't get recognized until they're a teenager or even an adult, right?
Mm-hmm, mm-hmm.
So how do you find those people to even
Right.
study is the real question, right? I mean, it's super important.
Yeah.
But I'd love to talk further about that with whoever is interested.
Yeah. I know there's a lot of good questions. It's like it's kind of like seems like the tip of the iceberg. Like there's a lot to be done still, and it's great that you're doing this research. And then let me look and see another question. What can parents of Black or Hispanic children do if they think their kids are not being identified or diagnosed correctly?
Yeah, that is an issue, because I've seen studies too where Black parents will often talk about how they went to their pediatrician or they went to their healthcare providers and they were not listened to.
Mm-hmm.
They weren't taken seriously, and so to get the provider to really take a look at the situation is hard. I think we need to do education at the provider level is what we need to do. So because we can't put it all on the parents and families, right? So to be able to get around, that sort of approach. And so one of the things, we did a study too where we looked at with Latino children, when they first noticed something, it was a national data set. So we compared Latino to white children, parents, when they first noticed something different about their child. There's not really a difference in age when they first notice something across these different groups. But so what did they do when they told the provider, and how did the provider react? And both Latino and white children's parents said that many of the providers said, let's wait and see, or they'll grow out of it, or things like that, right? So some providers did take a more active approach of doing a screening and referring for evaluation. And there weren't differences across the groups on whether providers took a more laid back approach or a more active approach, right? But what we did find is that for the Latino families, if the provider had taken a more active approach, they were more likely to get into the service system and get the services they need for their children. As with the white families, it didn't make a difference because maybe they already had a lot of advocacy skills and knowledge, about getting second opinions and things like that. So, so a lot of the Latino parents might rely more on what the provider says and listen to what the provider says. And if the provider's saying the wrong thing, that's not a good thing.
Yeah. So I guess that parent education is really important in advocacy and
and training providers.
Yeah, definitely. Okay, that's helpful. And then for a lot of this research, I know you were saying a big problem with kind of therapy and those types of providers and ABA and whatnot is that they're not everywhere, which is definitely true. So there's just whole areas where there's underserved, there's lack of access or transportation.
And rural communities too.
Same, yes, exactly. And what I was curious so some of the research that you've been working on in the models with the Promotoris models and having that parent engagement and teaching other families, is that something that could be rolled out to schools? Or are you guys looking at is there a way to, get into those communities and kind of empower more of those parents? I think where they are, it's like the vaccines thing, it's like going to where people are.
How can we scale it up, right? And yeah, no, that's a really good question. I mean, what we're trying to do is get the families with the kids early, even though we did intervention for kids between 2 and 8 years old. If they're diagnosed later, right, then they're not they need it at a later age. But I think it would be nice to do it with the early intervention programs or early childhood education, like Head Start and things like that.
Mhm.
Offer it there. And I know Sandra Vanegas is working with the Head Start program for the Aspen project in San Marcos. But schools, I mean, we're happy to work with schools. They're not always easy to work with, though, for research.
Yeah, yeah.
You know, that's they don't, you know, it's hard to get access to families that way.
Mhm.
Of other places. So we're the other thing is developmental clinics, you know, so as soon as a child gets diagnosed, they could be referred to a program like this from
Mhm.
the clinic and get that treatment. So that's what they do in Baltimore. They have a developmental clinic and they see a lot of low-income families and they get diagnosed with autism, but then what happens after that? So,
Yeah.
you know, this could be part of the follow-up for that.
Mhm. Mhm. Okay, interesting. And then what else was another question? I was just let's see. Okay, we did talk about, oh yeah, you talked about the PTA. What else was I going to say? Is there, oh, somebody asked, do promotores help promote COVID-19 vaccine rollout initiatives?
That's a great question. And there is a whole promotor association in Texas, actually, that I'm not actually in contact with yet. I have a colleague that is
Mm-hmm.
do more general health things, and I think they are involved in vaccine programs. And we're actually working, as the Texas Center on Disability Studies is working with other partners like the Texas Disability Rights and the DD Council. So we're
Mm-hmm.
working on a whole vaccine program right now. So I'm hoping to get them to think about using promotoras
Yeah.
for that, because to reach the harder to reach communities, right?
Yeah, it sounds like a good model. And also because you mentioned ABA and Medicaid, I was just going to say what we know about that so far.
Yeah, what
The ongoing saga that has just, yes, the program that never gets implemented. It is in the budget, so it's in the Senate and the House budgets, and we're hoping that it's getting implemented. And the last we heard was that it was going to be ready to come online February of 2022.
oh wow.
And so it keeps, you know, we had pushed for September 1st, like hard start when the funds become available. But, you know, they're saying there's lots of, they have to have public hearings and more steps and, you know, work with federal CMS and different things.
Okay.
So, you know, we'll definitely be pushing them and working on advocacy to do all of those things as quickly as possible, and not, you know, stall and delay on the hearings and the other necessary steps. But
Yeah.
it's looking more like February 2022, despite everyone's advocacy efforts.
That's a great update. And, you know, keep in mind that once it is implemented, the next barrier is going to be that providers will not want to take Medicaid. That's one thing I saw in some colleagues in South Carolina. They had gotten it implemented in the state for Medicaid to cover, and then they were having trouble getting providers to accept because it's lower reimbursement rates.
Right, exactly. So we'll have to see how that goes. And we've also heard from other states that, you know, Medicaid providers will do like an 80-20 or a 60-40 split. So they'll take 20% Medicaid clients or 40%. It does sound like something that might lend itself to wait lists and like I hope, you know, hopefully it's not going to be a huge problem, but you know, we'll hope for the best and we'll keep advocating. So, you know, everybody will just watch our Facebook alerts and we'll just keep monitoring that whole situation. Yeah, but that definitely is a huge lack of equity in treatment and access to therapy, and especially in the younger years. So it's, you know, it's definitely a huge need and very frustrating that it's taken this long. Yeah, so let me see, let me just double check one last. I'm looking at my I have a list of people's posted questions. I think that is all of our questions. Is there anything else that you wanted to talk about, Dr. Magaña, or mention?
Not that I can think of. I mean, I don't know if there's a way to share that link for people who want to.
Share the study link.
Yeah,
we can definitely share the study link if they haven't already. I don't want to play the Facebook thing, but we can add we can definitely add your study link, and then we can share that. And if parents need information, we always hold on, now that I looked, I'm like, I started on another computer, but yeah, parents can always contact us. Like if somebody asks like, what if you're not getting the correct diagnosis or school isn't, working and those kind of things. We're happy to find advocates, or, there's the UT Legal Clinic. There's just a lot of different like free resources that we can connect you with that project. So we're happy to help parents and steer them. So like some of these studies, when there's not treatment, there's other, there's a few different universities doing some really good studies on, and it kind of lends, it's like basically therapy, like free therapy. So, we've got lists of those going as well in the Aspen program. So there's definitely some options. I mean, it's not as ideal as having, therapy and access to everything you need, but there are some things out there available. So that are high quality.
Yeah.
So we're happy to help people. So I'm going to go ahead and share my screen really quick, because we've got a couple of events. We just wanted to tell people quickly about our next events that are coming up. And then in July, we are having the Autism Workforce Empowerment Day. And we've got the job surfing virtual showcase, but we'll be having employers come, and it's open to autistic adults 18 plus. And you'll make a video resume. So it's kind of it kind of takes the pressure off, and you can say what you want to say. We can help you and guide you through that. And then you'll kind of you'll tell us which employers you're interested in. So there's going to be some mini workshops and some different employment tips and some really good partners. We don't want to announce them yet, but we're talking to some really good employers right now. And I think it's going to be a great event. So that registration's open, and it's on our website, on our calendar. If you look at July 24th, and I think that it's probably posted on our Facebook page as well. And then our bike ride and fun run is usually, of course, usually in person, but we're doing it virtual again. This could be hopefully our last virtual event. But it's fun. And so we have a pet competition. You can walk or ride your bike. You do it on your own time. Send us photos of you or your pet doing, exercising around your neighborhood or your park. And it's also a fundraiser, and we've got all kinds of incentives and prizes, and you can win a pet portrait and all kinds of stuff. So this is kind of a really fun event. And it's going on now. So it's autismbikeride.org. And we're kind of doing a kickoff this Saturday as well. So that's a good event if you want to get, and all of these things pay for all of our free services and support. So if you want to do that, anybody wants to join, it is not too late. And I think that's really it. I'm going to stop sharing my screen. And Dr. Magaña, any closing thoughts or words of wisdom for us?
Well, just, enjoy the end of spring and the beginning of summer. I hope everybody's getting vaccinated now. We can get some of the older kiddos vaccinated, right? And
yes, that's exciting.
And so hopefully people will be looking to do some fun things.
Yes, we really hope so. I think everybody's ready to get out and move on from this pandemic. So it's thank goodness things are turning around a little bit. Great. All right. Well, Dr. Magaña, we always appreciate all your work and your time and research and dedication. And so thank you so much for joining us. And this will be up on Facebook, and everyone can contact us if they need to. And if you have questions about Dr. Magaña's study, you can email us as well. We'll post it, we'll share it. So everybody should be all set. So Thanks a lot, Dr. Magaña. All right. Have a good evening. And I'm going to stop this now. All right. Thanks very much.
Bye.
Okay, I stopped the live stream. I'm gonna